You have a question from Evie Martin. Let me just cut it and paste it to the screen. So Evie says, sometimes I'm conflicted about asking people about their lived experience. Is there a point at which it's best to steer the conversation away from the patient's pain experience?
That's a good question, and I find when I'm talking with students, they often kind of struggle with this balance in terms of how much emphasis to place on it. And my sense is that it stems from this feeling that sometimes patients can be talking about a lot of the same things again and again from their perspective. But I think that really kind of right at the beginning of assessment, doing a really good job at taking time to listen, taking time to kind of really unpack how pain has affected the person's life will just really provide a really solid foundation for the rest of treatment. And that even means that if you need to redirect their focus, then you might.
Oh, just a second, folks. Sorry about that. Oh, Peters, you were in the middle of your question there, Dr.
Let me start
Wideman.
again?
Yeah, so I'll show it again here real quick. Evie just asked about being conflicted, about asking people about their lived experience. Is there a point at which it's best to steer the conversation away from the patient's pain experience? Oh, and he's frozen again. He'll come back. There you are.
Try it one more time. I got the question. Yeah.
Sorry about
disappearing and coming back.
Yeah, sorry about that, guys. It's just technology. So
yeah. So the short answer from my perspective is really what I think is essential is that right at the get-go, as early as possible, you're giving the patient a lot of space and support to share their story about pain and really to kind of unpack how it's affected their life. And then that might cover a lot of different things. And as a primary care professional, it'll give you a lot of tools to figure out where your scope is, if you need to bring in other clinicians. And then what you'll be able to do later on, and I think this question kind of gets at that tension a bit, is that you'll be able to kind of help focus that conversation. So it's not that you always have to keep talking about all the different ways that pain has affected different aspects of life. You can bring focus to that. But I think particularly as a primary care provider, it's really important that you have that comprehensive understanding early on. And that'll give you license to kind of focus your therapeutic relationship and management strategies, and also help you bring in other professionals as they're needed.
Cool. I'm glad you got to finish the question.
Yeah, me too.
So we actually have another question, and this one is from Jessica Bayless, and it's a little long, so I'm going to show both. But my question is, I'd like to share my approaches with my clients to bring them in on how I work and what models I use. To what extent would you share the MAP model, and what do you think the benefits and limitations of doing so would be?
Yeah, that's a great question. I've actually, since I've been kind of sharing this with other folks and giving presentations, I've come across clinicians that have done just that, where they've actually kind of, and particularly the figure, they've shared that with their patients, and they found that was a really useful tool for them. And I think it's completely up to you, and it kind of whatever matches your style the best. I think that the model is really written to help provide clinicians with kind of some first principles in terms of how to approach pain. And so the idea is really kind of providing a foundation for how we can get on our patient's side, how we can kind of best listen, understand what they're going through, where our limitations are in that, and some strategies to do so. So it's really not prescriptive in terms of how you use it. So basically what I would say is if it's working for you, that's wonderful. And if you're wanting to share it with a client, that's also wonderful. And what I would whenever I do that with a client, I think the way that I'm presenting that is not from a definitive perspective, but kind of like sharing it as almost as a peer, if you will. And so it's kind of not saying that this has to be the way that we think about your pain or the way that it dictates our relationship in terms of how we're navigating pain, but this is one model to understand that. And so you're kind of bringing them in to the idea of kind of validating that and whether or not it's going to be a useful tool for you or not.
She actually has a second, slightly less relevant question. I'm not sure what this means. Do we know anything about whether Joe Cameron feels any emotional pain?
Oh yeah, so Joe Cameron is somebody I referenced in the talk, and she's an older woman. Yeah, no, that's okay. An older woman from Scotland who, if you remember, basically has never experienced pain. And this is kind of a real scientific discovery. And what's incredible about it is that it was only kind of realized later in her life. She only realized really that she was different from people in that respect later in life. And so the question is, does she feel, was it the question just emotion or emotion related to pain?
Let's see, let me pull it back up. Whether she feels any emotional pain.
Emotional pain. So, so first, I just want to challenge that term a little bit, emotional pain. So the way that we think about pain, it's the word "and" that is really key about it. So it's the sensory and emotional experience, and often we want to like tease apart those two things, but then it's not pain anymore. But with Joe, it seems like from her reports, basically that from an emotional perspective, just in terms of her life, she doesn't kind of feel the extreme highs and lows that she understands other people feel. So she doesn't feel like ecstasy and joy to the same degree that other folks do. But then she also doesn't kind of get down and kind of have some of those lower emotions that other folks do. And with pain, she just doesn't. She's never had an experience that she would call pain, and she's had multiple surgeries, multiple children. A lot of experience that other people would associate with pain. So no, she doesn't feel pain, which is including both that sensory and emotional component. And she also doesn't seem to have that kind of high and low range of just like everyday other emotions, which is really phenomenal, which is really interesting.
Cool. I'm actually going to probably extend the Q&A just a minute or two longer just because of the little freezing thing. We have another question from I believe this is from Sandy Hilton. What tips do you have for providers who want to encourage people to speak about their lived experience with pain and are short on time because of their organizational constraints?
Yeah, so that's a massive challenge, isn't it? So even if we are on board with kind of having a person-centered approach with care, we want to do listening, we want to do that assessment. There can be environmental constraints that really kind of in a meaningful way and a profound way limit us in doing that. So there are really like no easy answers here. And I think you have to kind of figure out some strategies that work for you and your environment and for your patient population. That said, I think being frank, I think saying, hey, I'm really unfortunately kind of limited on time. What I want to do is I want to figure out what is most important to you, and you can kind of lay that out to your patient so that they have a sense of that context that you're in, and they'll be the best person to kind of prioritize what is most important to them. And then giving that space where you're, even if your time is short, that you are listening to the response. And I think just as important as what you're saying to your patient is the tone in which you're asking it. So if you have body language that doesn't communicate that you're kind of open and eager to listen, I'm just gonna. I think I was just
again.
cut off at the end there. Yeah. So I'll just wrap up with that, and basically, tone is just as important as what you would say. And so I think making sure that you have a tone that communicates that you are supportive with your patient, and that you are eager to hear what they say.
Cool. So we have another question, and again, I just want to let the viewers know that we are going to extend this just a couple minutes extra longer, and then oops, hold on. Sorry, somehow there's like feedback. Okay. So we will go into the next question. We have a lot of good questions coming in here that I've been cutting and pasting. So the next question is from Matt Foster. Do you feel in an effort to emphasize and understand a person's suffering that you end up taking your work home and over-personalizing the patient's story? This was a trouble of mine early in my career. I won't show, there's the end where it says career.
So I think I got the question, and if you're okay, I'll just try to answer it the best I can. I think it's such an important issue. So I think that burnout can kind of really stem from that, and one of the ways that I understand that is that sometimes when we think about stigma, it can be a way that a clinician is in a way kind of protecting themselves a little bit from that baggage of caring a lot about other people, and that can be hard. And I think this is kind of getting at that. And what I think is that we don't spend enough time, and when I say we, I mean researchers don't spend enough time thinking about this. So I think that's a real challenge, and I think that we need to get better in our training in terms of helping clinicians recognize that emotional weight that they can be taking on, and also kind of how to manage that. And so what I would say is I would really encourage you to kind of walk that maybe more difficult path where you still are trying to empathize, you're still trying to understand, but you're really kind of investing in strategies that help you do that in a sustainable way, where you're not taking on too much of weight, you're not kind of over personalizing. So related to the word empathy, you can think about cognitive empathy versus emotional empathy, and maybe it's something to look at in terms of how to think about taking on less of that emotional weight of this, and be able to kind of focus a bit more on the cognitive side of this in terms of understanding the cognitive aspect of it. Is just one little line of work that you might want to explore.
So we have time for just one more question. We had so many great questions coming in. So hopefully some of you guys can join us backstage when we move back there. The last question we have is from Adi, and she is in Israel. Where do you see the line between psychology and your model?
That's an interesting question. So I don't quite know how to answer that. So what I'm assuming here is that we're not all kind of have one clinical background. My background's in physical therapy. And a lot of what I focus on is kind of how we can address psychological factors, but within a scope of physical therapy. And so with my students, one of the ways that I would train them to do that is really to kind of focus on end goals. So from a physical therapy standpoint, our bread and butter is helping people become more active and reducing disability. And what we know from research is that there can be a lot of psychological barriers to that. And I try to teach my students how to address those barriers, but always thinking about the end goal. And so thinking about psychological factors as helping to decrease barriers to get at engagement in physical activity, to reduce disability. And so if that's your clinical background, if you're coming at this from a physical therapy standpoint, then that can be a strategy that you could use as well to think about that scope of practice issue. In terms of the model itself, I think that it's a little bit higher level than that. And I really think, coming back to the idea of how we're thinking about pain, is that we need to challenge ourselves to not only think about pain as sensory or emotional, but really kind of challenge ourselves to keep those two things together. Otherwise, it's not pain, what we're talking about. And what I would say is that some of the ideas here in terms of giving space to understanding that lived experience of pain and the experience of pain, not just its symptoms, is, I think, just absolutely important for every professional. They're going to probably do that in different ways, but I really think it's important for all health professionals. Just before we wrap up, I just want to make a little plug for another presentation that's coming up on Sunday by Kat Glore. And Kat is somebody who's been living with pain, and she has just amazing talk that's Sunday at Eastern Time is 9 a.m. And the title is Seek First to Understand, Navigating the Language of Pain. And if this talk interested you at all, I think you'll be blown away by hers. And you can kind of think of it almost as this kind of first-person narrative, almost take on what I'm talking about here. And we didn't coordinate that at all, but we kind of just discovered through Rajam that was the case. And I really encourage you to check it out.